Hello again. I hope this is working. I'm back again. This is Dr. Velma Scanterbury coming to you live at the Dialysis Patient Citizens Educational Center. We had a little bit of computer glitch there, but I'm back, and I hope that you are here to ask us your questions. And we want to be able to communicate with you, talk to you about the issues of being on dialysis, issues of getting on the transplant list, issues of whether or not you're receiving the right treatment, what can you do to improve your lives while on dialysis, even considering if you're considering getting on the transplant list. You know, for many patients, there can be obstacles getting on the transplant list, but you want to be able to walk you through those. You want to be able to resolve those issues and get you the help that you may need to provide better lives and better treatment for yourself. And so it's very important that you communicate with your dialysis coordinator, your dialysis team, as well as talk to them about the options for dialysis. If you're not doing well on dialysis, we want to be able to provide you with opportunities to consider whether or not you are in unit dialysis, whether you are on peritoneal dialysis and experiencing issues, or if you are on home dialysis. And I know there's so many patients who are reluctant to talk about or even consider home dialysis because they may find that it's a hardship. But it's also very important to understand that the more you dialyze and filter your body, the better it is for your overall system. And to get those toxins out. And oftentimes patients are confused because they feel like they're on dialysis, but they're still making urine. And I think my kidneys are still working because I urinate every day. Well, that urine or liquid that comes out is not actually filtering your body. So the dialysis is necessary to be there, is needed to get those metabolites out of your system that your kidney is unable to do. And yes, if you're making urine, it's an advantage because you can balance your water intake a little bit better. And so you are able to take in probably more liquids than you would have if you were not making urine. Understand that not everyone will continue to make urine while on dialysis. So it's important to understand your body and your process. And so again, for those of you who are just joining, my name is Dr. Scanterbury. I work as a medical consultant for Dialysis Patient Citizens Educational Center, and I work with Nancy Scott, who's the Education Project Manager, and we are excited to come to you with our very first Facebook Live and to answer your questions. And so one of the questions that was just posed is, what is the expected duration of each dialysis session? What is the best way to add to the routine? And for many patients, what is the expected? Generally, you want a certain number of hours to be able to get your numbers back to a reasonable state. So it all depends on how much fluid you're gained, how high your numbers have risen. And so for many patients, if you're on dialysis 3 days a week, you do 3.5 to 4 hours a session. There are patients who dialyze at home and are able to do it 5 days a week or 6 days a week, just doing 2 to 3 hours each time. But the goal is just imagine how much you consume. If you eat 3 times a day, then you're going to have much more waste products and metabolites that need to be excreted. And you will find that patients over a long weekend, this weekend coming up is Memorial Weekend, many patients will not dialyze on Monday. And so they will have extra fluid on board that may play a role in how they feel and what they're able to tolerate, and therefore must and is necessary to get dialyzed on Tuesday. Those that dialyze on Saturday will be able to go to 2 to 3 days before dialysis on Tuesday, but it's important to look at your fluid gains. When you're not dialyzed and you're not making urine, then you're going to accumulate all that extra fluid that you have taken in if you haven't burned it off, and you can't urinate it out. So if you gain 5 kilos or 12 pounds, that's the 12 pounds of fluid that your heart now has to work with. And that can play havoc on your heart. So it's important to stick to your regimen of dialysis and your routine. Don't cut your treatments short, because all you're doing is not allowing your body to filter and to adequately filter the waste products that need to be excreted or to be removed by the dialysis machine. And that is in place of your kidney. And that's why it's so important to stick to your routine. Many patients feel that, maybe it's okay to not go once, maybe just go twice a week. No, that's not enough. It's just you're eating 3 times a day, you're consuming waste products, and so you need a way to get that system, those waste products out of your body. And if you have a kidney transplant, now that kidney transplant will, even though it's one kidney, will continue to do the work of your body and of both kidneys, and so your body will gradually improve and to the point where your creatinine can be as low as 1 or less than 1, and you can continue to function with that one kidney. But now you are able to urinate more, and you're able to urinate as a normal person, and that kidney is now filtering your body instead of the dialysis. And that's the advantage of having a kidney transplant, is now your creatinine doesn't remain high, and you're just getting rid of the excess. Now the body is able to cleanse that. And so patients can, while you're only receiving one kidney, it can do the function. Many people are born with one kidney and do just well as well. Another question that came up is, what's the maximum number of transplants that a patient can receive? The maximum that I've ever given one person was 5. Generally, the first kidney is placed on one side, left side or right side. The second one, you go to the opposite side. When you get to the third kidney, you usually take out one of the old kidneys to put the new kidney there. And I've only had 2 patients get above 4 kidneys. Generally, the body will react to having this foreign tissue in their bodies, and so by the time you get to a third kidney, your body has seen the genetic makeup of 3 different people. Generally, for these patients, they develop antibodies to the genetic material of the previous donors, and it makes it very difficult to get a 4th kidney or even a 5th kidney. So those are patients who wait longer on dialysis and unfortunately may not survive to even get a 4th or 5th kidney. Technically, it becomes a challenge of where to put them, but oftentimes you may go inside the abdomen closer to the bladder, because the goal is to be able to, you can place the kidney in the blood vessels as you can go higher up, but you still need to be able to connect the ureter, that drainage tube, to the bladder, so that person will be able to make urine in a normal way. So it's a little bit complicated. Unfortunately, the antibodies that your body developed in a defense mechanism against those previous donors that you've been exposed to through the transplants can inhibit many people from getting a 4th kidney, and very rarely a 5th kidney. So that's important to know, but it should not deter you. The goal for us as transplant surgeons is to really maximize the life of each kidney. No kidney is going to last forever unless you happen to be an identical twin. Then your body will see that kidney as absolutely you, and you will need very little to no anti-rejection medication. But everyone else, if you're a sibling, if you're a parent, if you're a cousin, if you are unrelated, you will require anti-rejection medicine to keep your body from recognizing that kidney is foreign. And the goal for some people who may share nothing in common with the donors can still get 10, 12, 15, 18 years out of one kidney. And then there are others who may not be able to get that longevity. But that's why you need to be monitored. That's why you need blood work. That's why you need medications. And the goal is to be able to maximize longevity. And while you have that kidney, your body is returning to normal homeostasis. You're able to excrete all of those metabolites. You see patients on dialysis get darker because of phosphorus accumulation in their skin. And so as you get transplanted, you see patients get back to their normal skin tone because your body is now able to excrete all those metabolites. And so another question is, are there any physical or mental health conditions that can complicate dialysis treatment? Certainly it's important to understand that your ability to tolerate dialysis is really about being able to manage that fluid balance. And one of the biggest downsides to long-term dialysis is heart failure. So you want to be able to avoid the highs and lows of your volume. If you watch your diet, limit your intake, and don't challenge your heart, you can do well on dialysis. Physically, it's a challenge when trying to get patients to understand that if you're not making urine, you need to limit your fluid intake, because you turn your heart into like an accordion, increasing your volume, decreasing your volume. And so heart failure becomes, cardiovascular disease becomes the biggest downside and the cause of death for many patients on dialysis. So stick to your diet, stick to your volume, stick to your dialysis. And if you do it at home, as Ms. Cheryl Johnson said, you can do well, because home dialysis, you do it on your time, you do it on the 5-6 times a week if you so, and so you achieve that better balance overall. So what happens when a patient always forgets to take their binders with meals? Well, the dialysis the dialysis machine is not able to take off phosphorus, so you really need your binders to get that out of your system, and phosphorus can build up. And so it's important to figure out a way, either limit your intake of foods that are high in phosphorus, and therefore, but you still need to take your binders, because that can become very high and can be a big factor in deposition that occurs in your blood vessels, for instance. Can ruin significant cardiovascular disease. It can really mess up your system. And so it's important to take your binders, because you will see patients who have normal blood vessels when they started dialysis, and in 3 or 4 years not compliant with their binders, and now their blood vessels have a lot of deposition and what we call arteriosclerosis. So that becomes very important to be compliant with your taking your binders. If there may be different ones. If we can't tolerate one, you may talk to your doctor or your healthcare team about other options for you, and also limiting the kind of foods you eat that may be contributing to a high phosphorus, or so that you're not requiring as many binders to take. So what are the financial costs of dialysis, and what resources are available to help maintain these costs? Well, dialysis is actually, once you develop end-stage renal disease and require dialysis, Medicare covers the cost of dialysis. So it becomes a disability, and so end-stage renal disease and dialysis is covered by Medicare. So you qualify for dialysis unless you're not a resident of this country. You should qualify for Medicare, and so there are different options out there for you. If you're under 65 and over 65, it may be different criteria for what other opportunities you are available for in terms of financial costs. How you cover your meds? Did you work before you ended up on dialysis? Did you have any additional plans, medical plans that may help you with your medications? And so there are financial counselors within your dialysis unit that can help you with these resources, opportunities to look at how you pay for your co-pays, how you afford your medications, those sort of things. And so this is also one of the opportunities to be in the community of dialysis patients, citizens, educational center, not only to learn more, but to also to connect to different resources that may be available on the website at dialysis patients, citizens website. So I encourage you to click on the website and learn more, and also to see what opportunities that are there for you to, as a member, to join or to access, as far as policies, things that are going on within your state, questions that you may have in order to answer. So what are some of the reasons that sepsis occurs in dialysis patients? As you realize, when you get dialyzed, you're introducing whether it's a foreign substance such as a needle is going through your skin into your blood vessel, so that they can remove your blood through a machine and return it back to you. Whether you have a fistula, whether you have a catheter, your risk depends on your source or your access. Certainly, if you have a dialysis catheter, you're more likely to be at risk for infections, because that catheter site may get contaminated. You're supposed to keep it clean. You clean the tip, but you still may have a source of infection from that foreign body and from that connection. Going through your skin, you should make sure that your skin is clean if you're going through your fistula. And accessing those sites, if you're doing it at home, you want to make sure those who do home dialysis are aware of the sterility that needs to go in and the process to keep that site clean and to not contaminate the needle with outside bugs or bacteria that may be on your skin that may get introduced into your system. And that's how most patients will get infected, from having an outside infection or outside bacteria get into their bloodstream, either through the site or the needle, the skin. Usually it's a source of skin bacteria. Some patients may get sepsis because of an infection that they may have that spreads to their bloodstream. Let's say, for instance, they have a exit site infection that can contaminate and get into your bloodstream and become develop bacteremia. So any kind of you can have a urinary tract infection that may go to your kidneys, or an abscess in anywhere that can then get into your bloodstream. So sepsis is when bacteria gets from the site of where it entries from your body into your bloodstream. So that becomes important to understand why it's so important to keep your dialysis sites, whether you're on PD, anything that foreign substance, bacteria tends to want to live around them, whether it's your dialysis catheter, keeping those clean, keeping the way when you connect those connections clean. So that becomes very important. So thank you for that question. That was one of the things that we worry about with patients on dialysis, is avoiding infections and making sure that, especially when you're doing it at home, that you have an environment that can keep your area clean, keep your room clean, avoid pets from coming in or being close to your equipment and contaminating even your own skin. So one of the questions was about what's the difference between peritoneal and hemodialysis. And hemodialysis is, as a hemo means your blood system. So we're dialyzing using your blood. And so whether it's via catheter in your neck to begin with, or a fistula, so the dialysis machine is taking your blood out of your body, filtering it, and returning it to your body. Peritoneal dialysis is when you have a catheter that is placed inside your abdomen, and once that catheter and the site is healed, a high dialysate fluid is then instilled into your abdomen. And the surfaces of your abdominal cavity, the surface of your small intestines are all lined with what we call peritoneum. And that can be become a source of filtering. And so the fluid within your abdomen will stay there for a certain amount of time. And you let it dwell in, and then you take it off. So peritoneal dialysis is in your peritoneum or in your abdomen, using your peritoneal surface as a filtering mechanism to take the waste products out of your small capillaries and your blood vessels and back into that fluid as a transudate that then gets where it's then excreted, where you exit and empty the fluid at the end of the day or after 4 hours. And this is repeated on a daily basis. So that's one of the things some patients, especially for young people who may be an advantage not being hooked up to the machine. Peritoneal dialysis, once you're correctly taught how to do it, you can do it at home. Parents can help these young kids and young teenagers to do it so that they're not hooked up in a dialysis center. So that's a easier way. It's less cumbersome. You're able to travel more, and you have probably less dietary restrictions with peritoneal dialysis than hemodialysis. And so it's one of those options that should be given to patients depending on your body size and what your doctor sees as you may have risk factors that may not, that would make you not a great candidate for peritoneal dialysis, and that's important to know. Another question is, are there any specific risks or considerations for elderly patients starting dialysis? One of the things especially that we would often suggest for elderly patients who may have more trouble on hemodialysis because of heart issues, heart failure, or inability to tolerate volumes in terms of being increase in volumes between dialysis, is that they may do better with peritoneal dialysis if they have a body habitus that allows that to be permissible. So for many of the patients who are over 75 or over 70 who may not qualify for a transplant, or may have underlying heart disease or cancer, other things that may inhibit them from getting a transplant, oftentimes peritoneal dialysis may work better for them because one is less stressful on the hearts because of less volume changes. When you're doing dialysis, you're taking off fluid and you're putting on fluid between dialysis, and so it's much more tolerated for patients who are elderly. So is there an age limit for an individual to be considered for a transplant? Generally, the upper limit of transplant is going to be varying from transplant center to transplant center. Some centers will have an age limit of 75, others will have an age limit of 70. They may do patients over 75 if they come with a living donor, because when you're that age, sitting on the transplant list waiting for a kidney is very unlikely that you will get a match, considering that younger people, the younger you are, the more likely you are to get transplanted. So if you are 75 and you come with a living donor, it's likely that if you don't have other risk factors that may exclude you from being a transplant candidate, you have to be medically cleared and you have a living donor, then it's likely that there are some programs who may accept you at that age. Oftentimes it varies depending on the donor availability in that area and the likelihood that they'll find you a donor. But the best bet as we get older is certainly to find and have a living donor who you know will donate to you, and you're not necessarily competing with all the thousands of people in that area that are waiting for kidney transplant as well. So for many patients, we encourage them to, as you know about the fact that you're hitting stage 5 renal failure, think about living donation. Think about whether or not there's someone, a loved one, or someone else who may want to give you that kidney and give you that gift of life, so that you don't even have to get on dialysis. Many patients think you have to be on dialysis to get transplanted. No, if you are aware that you will, your kidneys will fail, if you have an early diagnosis of kidney disease and are gradually getting worse, and you have someone who wants to donate to you, that can be set in motion as making sure that you're cleared for transplant, and that transplant can occur without dialysis occurring. It can be put in place so that the donor is worked up and you can move from, now you need alternative treatment, your medications and diet isn't working, and your numbers have gotten so bad that your nephrologist is saying it's either dialysis or transplant. At that point, transplant can be scheduled at the convenience of both your living donor and you as the recipient, and proceed with transplant and avoid dialysis altogether. But that requires knowing that someone is willing to donate to you, and that is certainly a wonderful gift that many patients have had the advantage of being able to do. But for most patients, they're able to get on the transplant list and wait, depending in your area, how long it may take. Last question, are there any promising research or innovations in treating kidney disease beyond dialysis and transplantation? Certainly there's a lot of work going on with the artificial implantable kidney, but because of funding, they have not been able to have rapid advances in allowing it to come to fruition as we would like. And so from that standpoint, it would be wonderful to be able to have an alternative, to have an implantable device that can save the lives of so many patients who are unable to get a transplant. But that's a topic in itself, and maybe one of our Facebook lives or Instagram, we can hit on such an information of where are we with the implantable kidney device. It is 1 p.m. I thank you guys for being here. Can a person lose their place in the transplant list after declining kidneys? No, you don't actually lose your place. You actually will remain there. You don't get penalized for declining kidneys unless you do it over and over again. So then we need to have a sit down and have a chat to figure out what are your objections and do you really want to be transplanted. So I enjoy this 30 minutes with you. I very much appreciate you coming on, asking questions. This is our very first Facebook Live here at Dialysis Patient Citizens Educational Center. And we'll be doing this once a month, as well as Instagram Live once a month. So have your questions ready to ask. You can go to our website to post your questions as well. And I look forward to working and seeing you more and more in the coming months. Have a blessed weekend. Enjoy your Memorial weekend coming up. Be safe. Watch your diet and follow those recommendations of your doctor so that you don't end up being chastised next week. So have a wonderful weekend and God bless.